Okay, so welcome everyone to the Usmle Step 1 Reproductive Lecture number 3 by Dr. Hysterectomy. Thank you so much for joining the lecture. Hope you guys are doing well. If you guys can hear my voice, can I get a yes in the chat box, please? Okay, good. So thank you so much for joining the class. Till now, we have finished a couple of high yield discussions from the reproductive system. We have finished our discussion of reproductive embryology. Today, we will jump into the lecture of reproductive anatomy. And is everyone ready? Yes or no? Is everyone ready to begin? Yes or no? Okay. So first, let's talk about the drainage of the ovaries and the testis. Okay, so gonadal drainage. Now, when we talk about drainage, what we're talking about is what are the things that are being taken away from an organ. So you basically have two major drains of any organ. One drainage is your draining of the veins, the venous blood. Another one is the draining of your lymph by the lymphatics. So whenever we talk about draining, these are the two things that we are referring to. So venous drainage, the left one and the right one, the left ovaries or the left testis will drain into the left gonadal vein, and then the left gonadal vein will drain into the left renal vein. And the way that this happens is that, as you can see, that the left, for example, let's say that this is the left renal vein. As you can see, this left renal vein, and this is the left-sided testis, for example. So the left-sided testis will drain into the left, excuse me, my apologies. The left-sided testis will drain into the left gonadal vein. But then, as you can see, that these gonadal vein, they will drain into the left renal vein at a right angle, at a 90 degrees. The fact that it drains in the left renal vein at a 90 degree, the turbulence of blood and the resistance to which the vein drains into the inferior vena cava is much higher on the left side when you compare it to the resistance to the blood going back to the inferior vena cava on the right side. So what this does is that this creates a backflow, and this creation of backflow easily causes congestion and buildup of blood, which is one of the major reasons why a pathology such as varicocele. Varicocele are basically dilated venous plexus. So varicocele are more common on the left when you compare them to the right. Why do we get these sort of varicocele on the left side more than the right side? One more time. The answer is because one is that the left gonadal vein, they drain at a right angle. So this creates a high resistance, number one. And number two is that on the right side, as you can see, that the right gonadal vein will drain directly into the inferior vena cava. They do not have to drain into the right renal vein. So since they do not have to do that, the blood flow back to the inferior vena cava from the right side happens at a much lower resistance, and this allows for all the blood to go back to the heart. So that's why always remember this, that varicocele are more common on the left. Very, very high yield. Okay. Next one is lymphatic drainage. Lymphatic drainages of the gonads are very important because whenever we have some sort of a carcinoma or some sort of any pathology, for example, and if we have swelling of those lymph nodes, then those swelling of the lymph nodes are a sign that there is a very high yield underlying pathology. For example, whenever we see para-aortic lymph node enlargement or pathologies in your US70 step 1, instantly we assume that there's something wrong with the ovaries or the testis. As simple as that. For example, the most common reason is testicular carcinoma. Next one. Next one is, for example, the body of the uterus and the prostate. So let me just draw a diagram very quickly so that it's easy for you guys to understand. Give me 1 second. So this is how the diagram is. For example, this is the uterus. Okay. use the uterus with the fallopian tube. Okay. This is the fundus body, and then the lower vaginal cervix. So that's that. Okay. So for example, over here, the body of the uterus, meaning that this whole part, right? The body of the uterus, all the way up to the cervix. Okay, all the way up to the cervix. This is drained by the external iliac nodes. External iliac nodes. Then the body of the cervix is drained into the body of the uterus and the body of the cervix. This one is drained also in the external iliac nodes. Okay. Then you have the lower portion of the cervix. So the upper cervix is draining into the external iliac. The lower portion is draining into the internal iliac. And then you have the distal vagina, vulva, all of them, these portions, they're all draining into the deep inguinal nodes. Deep inguinal nodes, as simple as that. So from above downwards, it's external iliac, internal iliac, and then deep inguinal nodes. Deep inguinal nodes, or into the superficial inguinal nodes. So mostly it's into the superficial inguinal nodes, but deep is usually for the glans penis and the glans clitoris. But for females, it's superficial inguinal nodes. So one more time, external iliac, internal iliac, and then superficial inguinal nodes. Have I made myself clear? Yes or no? And then over here, you have two ovaries, one ovary over here, another ovary over here. These are draining into the para-aortic. Are we clear, guys? Yes or no? Fast answers, please. Did we understand the lymphatic drainage of the female reproductive system? Yes or no? Can I get some feedback in the chat box, please? Did we understand or did we not understand? Fast answers, please. Oh, are you guys also drawing the diagram by any case? Okay. Okay. Next one. Next one is for males. For males, what do we have? Let's say for males, let's begin with the bladder, right? Then from the bladder, let's say that we have the urethral tract. And let's say the prostates on each side. And then you have the penis, the penile region. Okay. And you have the testis, like this. So these testes, they are going to drain into the para-aortic. Okay. Then this superior portion of the bladder, this is going to drain into external iliac. Okay. Then you have the prostates, and then you have the corpus cavernosum. They will drain into the internal iliac. So prostate drainage is into the internal. Prostate drainage is into the internal iliac nodes. Very important to understand, because whenever we have a prostatic carcinoma, if there is any lymph node which you should check first, then this is the internal iliac lymph nodes. Then next one. Next one is that we have the scrotum, right? The scrotum is draining into the superficial inguinal, and then we have the glans. The glans penis is draining into the deep inguinal nodes. Okay, so one more time. Superior portion of the bladder, external iliac. Testis, para-aortic. Prostate, internal iliac. Corpus cavernosum, corpus spongiosum. They're also, my apologies, they're also draining into the internal iliac. And what I wanted to say is the scrotum, right? This scrotum on each side, they are draining into the superficial inguinal, my apologies. And the glands into the deep inguinal. That's simple. Okay, now very quickly, if we have an ovarian carcinoma or a testicular carcinoma, which lymph node should we check first? First answers, please. The answer is para-aortic. Very good. If we have a prostatic carcinoma, which lymph node should be checked first? If we have a prostatic carcinoma, which lymph node should be checked first? Internal IVA. Very good. Okay. On which side do we have more varicocele? Left side or right side? More on the left side. Okay. There's another very high yield diagram, which I want to draw right now. Okay. So let me just draw that diagram very quickly. Okay. Yeah. So what I want to draw is the ligaments that are responsible for holding the uterine and the ovarian structures in place. Okay. So over here, one more time, you have the uterus, very roughly. You have the fundus, body, cervix. These are the fallopian tubes. These are the ovaries. And this is the lower part of the uterus, the superior part of the cervix, and the lower cervix, something like that. Okay. So what I want to talk about is that over here you have the abdomen, right? You have the wall of the abdomen over here on each side. This is a very rough diagram. This is basically created to make sure that you understand each and every ligament very properly. Now, I'm going to use different colors for different ligaments. So the first one that I want to talk about is one of the most highest yield. The color that I'm going to choose for this is blue. This ligament is responsible for suspending the ovaries from the lateral wall of the pelvis. So you have the pelvis wall. The pelvis is basically the bone, right? The pelvis bone. So for example, let's say that this is the wall of the pelvis, right? This straight line is the wall of the pelvis. And the ligament that attaches the ovaries to the lateral wall of the pelvis, like this blue one. This ligament is very important. This is called infundibulopelvic ligament, or we call this suspensory ligament. So blue is for suspensory ligament. Is everyone understanding? Yes or no? Does everyone hear my voice? Can everyone understand the lecture? Yes or no? Fast answers, please. Okay. So first, this is the blue ligament. The blue ligament, the name of the blue ligament is which one? The name of the blue ligament is what? Fast answers, please. This is the suspensory ligament, or what is another name of suspensory ligament? Infundibulopelvic ligament. Very good. Okay. So that's it. Next one that I want to talk about is I want to talk about this ligament. So for this, I'm going to use green. Okay. This is for the cardinal ligament, or we call this, another name is transverse cervical ligament. If this is called the transverse cervical ligament, is it attaching the cervix to the lateral wall? Yes or no? Fast answers, please. Yes. Okay, good. So the next one that I want to talk about is another ligament. Another ligament that I want to talk about is this ligament. This is a ligament that is attaching three things. Number one, ovaries. Number two, fallopian tube. And number three, the uterus. All three of this to the side wall. One more time on this side, ovaries, fallopian tube. Okay. What is the name of this ligament? Can anyone tell me? The name of this ligament is? This is known as the broad ligament. Very good. This is called the broad ligament. Okay. Now there's another ligament that's like this. This ligament is, I'm going to use a brownish color for this. This is basically connecting the ovaries to the uterus medially. Ovaries to the uterus. Okay, medially, like this. What is the name of this ligament? This ligament is called ovarian ligament. Have I made myself clear? Yes or no? This is called ovarian ligament. Now, there's another ligament called the round ligament of the uterus. Now, the round ligament of uterus is basically connecting the uterus to the labia majora to make sure that it stays in place. It's very difficult to draw the round ligament of the uterus because for that, the structure is basically a three-dimensional structure. So it will be something that's coming forward like this. So I'm not going to draw the round ligament, but one more time, very quickly. What is the name of the blue ligament? Fast answers, please. That's connecting the ovaries to the lateral wall. Okay. Can I get the help of one physician over here? Can I get the help of who can help me out with this? Fast answers, please. Please add me in the chat box. All you have to do is name the ligament. Hey, Dr. Ethar, thank you so much.
Yes.
What is the name of the blue ligament?
The ovarian, no, the suspensory ligament or infundibulopelvic ligament.
What is the name of the green ligament?
This is the cardinal cervical, transverse cervical ligament.
Thank you so much. Okay. Next question is for Dr. Tahera. What is the name of the black ligament? Broad ligament. Very good. What is the name of the brown ligament? Ovarian ligament. Very okay. What is the name of another ligament? This question is for everyone that is connecting the uterus to the labia majora. That's please. Round ligament. Okay, very good. Now, what are the pathologies associated with each ligament? So before we understand the pathology, let's talk about the blood vessels. There are two major blood vessels to the uterus and the ovaries. And the names are very simple. For uterus, the blood vessels are known as uterine arteries and uterine veins. For ovaries, it's ovarian arteries and ovarian veins, so ovarian vessels and uterine vessels. The question is, where do both of these ligaments, or which are the ligaments that are carrying these blood vessels? The infundibulopelvic ligament over here, the suspensory ligament, this is responsible for carrying your ovarian vessels, because it makes sense that the blood supplies, they are going to come laterally through the pelvic wall. So that's why they take the help of the infundibulopelvic or the suspensory ligament to come to the ovaries. And another blood supply is the uterine supply. The uterine supply comes to the green one. The green one is called cardinal ligament. Okay, so with the cardinal ligament, you have the uterine vessels. Now, very quickly, if there's a female who comes to you with extreme fever, nausea, vomiting, severe pain in the lower part of the uterus, and let's scratch the fever. There's no fever. Let's say that there's sudden excessive pain after playing a game. A female comes to you with excessive lower abdominal pain, vomiting, nausea, and you do an ultrasonogram and you see that the ovaries are devoid of blood supply. What is the name of the pathology? Fast answers, please. Torsion. Which ligament do you think has undergone the torsion? Fast answers. Suspensory ligament. Okay, that's simple. Next one is there's a gynecologist who is performing a hysterectomy. If they're performing the hysterectomy, which ligament do they have to ligate in order to get rid of the blood supply? Cardinal ligament. Very good. Okay, cardinal ligament. Okay. Next one is what is the name of the ligament that is connecting the ovaries medially to the uterus? Fast answers, please. Medially to the uterus. Connecting the ovaries medially to the uterus. The name of the brown ligament. What is the name of the brown ligament? Very good. Okay. This is called ovarian ligament. Do you guys remember gubernaculum testis, the band of fibrous tissue that is pulling the testis down from the inguinal canal all the way to the scrotum? Yes or no? Do you guys remember gubernaculum? Gubernaculum testis? Yes. Okay. So in the females, the female derivative of gubernaculum is that there are two derivatives. Number one is the round ligament, the one that we did not draw, that will connect the uterus to the labia. Another ligament that we did draw is the ovarian ligament. So these two are the derivative of gubernaculum testis. Okay. So did we understand everything about the ligaments? Yes or no? Fast answers, please. Okay. Another high yield question. What is the name of the ligament, or which ligament out of all of these uterine ligament is formed from the fold of peritoneum? Formed from the fold of peritoneum. Fast answers, please. Broad ligament. Very good. So broad ligament is the ligament that is formed from the fold of peritoneum. So one more time, quick questions and quick answers. Is everyone ready? Yes or no? Is everyone ready for quick questions, quick answers? Yes or no? Okay. What is the name of the ligament that is connecting the ovaries to the lateral wall? Fast answers, please. What is the name of the ligament that is connecting the ovaries to the lateral wall? Suspensory ligament. What blood vessels are they containing? Fast answers, please. What blood vessels are they containing? Ovarian vessels. What pathology is associated with infundibulopelvic pelvic ligament? Fast answers, please. What is the name of the ligament that is attaching the ovaries medially to the uterus? Medially to the uterus. The name is ovarian ligament. Very good. Is this a derivative of uberniculum? Yes or no? The answer is yes. What is the name of the ligament that is connecting the cervix to the lateral wall to the side of the pelvis? The name is cardinal ligament. What blood vessels are carried in the cardinal ligament? What blood vessels are carried in the cardinal ligament? Uterine. What is the name of the ligament that is formed from the fold of peritoneum and that is connecting the uterine, the fallopian, and the ovarian? Very broad ligament. Okay. What is the name of another ligament that is connecting the uterus in front with the labia majora? The name is? Fast answers, please. What is the name? Round ligament. Okay, very good. So can we say that we have understood the ligaments of the testis very properly? Yes or no? Very high yield, especially this one, and this one. Okay, very high yield. Now, let's move on to adnexal torsion. Okay, what is adnexal torsion? Adnexa is basically the term that is used to define the ovarian and the fallopian tube structures. So adnexal torsion basically means that there has been some sort of a twisting of the ligament. Which ligament are we talking about? We're talking about infundibulopelvic ligament and ovarian ligament to some extent, which can cause compression of the ovarian vessels, blocking of the lymphatic and the venous outflow. As a result, the arterial perfusion, the arteries, they keep on supplying the blood to the ovaries, but the blood cannot leave the ovaries through the veins. As a result, can we expect the ovaries to get swollen? Yes or no? Fast answers, please. The answer is yes. So as a result, we can have ovarian edema, swelling, very, very pain. It's a very, very painful situation, which is also associated with nausea, vomiting, because there's complete blockage of arterial inflow at one point. When there's excessive edema, what happens? For example, let's say that this is the normal structure of the ovaries, right? And these are the blood supplies of the ovaries. At one point, when the ovaries will get really big, like this, will get really swollen, will the blood supplies get really thinned out? Yes or no? Will they also be stretched out? The answer is yes. When the blood supplies, when they get stretched out, will they become very prominent? The answer is yes. So will we have a lot of blood supply in edema or less blood supply in edema? Fast answers, please. The answer is that we will have a lot of blood supply or less blood supply. Fast answers, please. We will have less blood supply. Let me make you understand another way. For example, let's say that this is one organ and this is the blood supply of the organ. If all of a sudden, if this organ gets super big like this, the blood supply to the organ, can they be varicose? Yes or no? The answer is yes or no. The answer is yes. In that case, can this small amount of blood supply the entire big organ right now? Yes or no? The answer is no. So do we have cessation of blood supply to the ovaries? The answer is yes. So very quickly, I just need you guys to notice a very high yield thing over here. You have artery, vein, and lymphatics. Initially, in an ovarian torsion, which two blood supplies or which two supplies are not going through? The answer is venous supply and lymphatic supplies are not going through. But initially, is artery supply going to the ovaries in ovarian torsion? Yes or no? The answer is yes. Is this why we have the artery supply, but the veins and lymphatics are not there, for which the ovaries get enlarged? Yes or no? The answer is yes. The ovaries get enlarged. Once they get enlarged, is it only then that the blood supply to the ovaries get blocked off? The answer is yes. Okay. So complete blockage of arterial inflow. As a result, there's necrosis and local hemorrhage. It's associated with ovarian mass and acute pain, and it's a very high yield surgical emergency. What is the surgery? The surgery is emergent laparotomy. Okay. Are we clear? Yes or no? Okay. Very good. Wait 1 second. Let me see. Okay. Okay. Do we have Dr. Singh with us today? Yes or no? Dr. Bipul Singh. Can you hear my voice? If you can I get a yes, or if you would be kind enough to unmute yourself very quickly? Dr. Singh. Yes, would you be kind enough to unmute yourself very quickly? Yes or no? Background noise, okay. So thank you so much, Dr. Singh, for coming and joining our class. Dr. Singh is a student from our previous batch who has joined our class one more time, so thank you so much. If you have any questions, please let me know. And from time to time, I know that you are very helpful in helping us solve questions and participating actively in the class. So if your background noises decreases, please let me know so that I can ask you some questions regarding the lecture. Okay, who can I ask some questions very quickly? Please say me in the chat box. Dr. Singh has background noise. Who else is free of background noises for me to ask them some questions? Please write me in the chat box very quickly. We do not have a lot of time. One question, all they have to do is make me understand the pathology of ovarian torsion, and then I'll move forward. If I do not get any help, I probably will not move forward. Anyone who can help me out, please? Okay, Dr. Ita, thank you so much. Please unmute yourself and tell me the pathology of ovarian torsion.
Yes, the thing that the ovary is gonna twist around the infundibulopelvic ligament.
Why does this happen? Why do ovaries twist?
Why? Maybe it's the cause, you mean, like trauma?
Yes.
Or maybe
Cause.
or tumor, maybe.
Very good. So there could be another underlying pathology. There could be tumors. There could also be. Can we also get this idiopathically? Yes or no?
Yes.
Okay. Can we also get this during pregnancy? Yes or no?
Yes.
Okay. If we get this during pregnancy, do we need to wait till the pregnancy, or do we address this disease immediately? Fast answers, please.
I don't know.
So we address this disease immediately. Okay. Because in pregnancy, if the ovarian torsion, if you do not solve the ovarian torsion, then can the mother survive? The answer is no, right? So if the mother doesn't survive, then the child doesn't survive. And another question very quickly, since we are on the topic. If you have a pregnant mother who comes to you with acute appendicitis, do we treat the appendicitis? Yes or no?
Yes.
Yes, very good. Okay, because once again, if we do not treat the appendicitis, the mother may die due to sepsis. So if the mother dies, then the child dies. This is the same ideology behind, for example, in planes, Dr. Etha, for example, in planes, have you noticed that whenever the oxygen mask comes down, they ask the mother to wear the mask first, and then they ask the mother to wear the mask first, and then they ask them to put it on the children. Do you know why? The answer is because if the mother doesn't survive, then the child will not survive. So best take care of the mother first, and then the child. So that's the thing. Okay, now let's go back to our lecture very quickly. What is the pathology of the ovarian torsion? So let's say there's a patient who comes to you with torsion. What are the two supplies that will get cut off initially?
The venous outflow and the lymphatic first.
And the arteries, will they keep on supplying blood?
Yes.
Okay, so will we have swelling of the ovaries? Yes or no?
Yes, ovarian edema.
Okay. So if there's swelling of the ovaries, then at one point when the ovaries are very swollen, can we have decrease of blood supply to the ovaries?
Yes.
Okay, very good. Okay, so thank you so much. Okay, so the main reason why I'm discussing this with you guys is that there are questions in the Usmle step 1 where they give you this sort of things, for example, artery, vein, and lymphatics. And they give you, for example, cross, into like this ABCD structures. Yes or no? Isn't this sort of way how Usmle makes their questions? They give you artery supply and stuff. So I want to make you guys notice that initially the artery supply is okay. The venous supply and the lymphatic supplies are the ones that are not there. And then in the later stages, when the ovaries get really big, then we have cystine of arteries, vein, and lymphatics. Okay, so something for you guys to notice. Okay, so that's that. Let's move on to the next pathology. The next pathology is also very important. This is called pelvic organ prolapse, right? What is pelvic organ prolapse? This basically means that the ovaries, my apologies, that the uterus, for example, or any other pelvic organ, if it comes down through the through the cervix, right? If there's herniation of any of the pelvic organ beyond the vaginal wall through the cervix, then we can call this pelvic organ prolapse. That's simple. Now, what are the risk factors of pelvic organ prolapse? The risk factors are that, for example, the number one risk factor for pelvic organ prolapse is multiparity, that is, being pregnant at least 5 to 6 times. So, or at least more than 2 to 3 times. So what that does is repeated pregnancy causes laxity of the uterine ligaments. And this also causes the organs to get herniated very easily. That's number one. Number two is age is a very high yield risk factor because the older we get, the more laxity we develop in our connective tissues. That makes sense, right? Another one is if there is a high amount of abdominal pressure, for example, in case of a female during the second or the third pregnancy, if she is morbidly obese for any reason, then let's say that the intra-abdominal pressure, the high amount of intra-abdominal pressure will press down on the uterus, and this can also facilitate the pelvic organ prolapse. So that's it. So risk factors are very important because this is how the question will describe the patients to you, that a patient comes to you with a history of multiparity, or a patient comes to you whose age is above, for example, let's say 42 or 43, or a patient comes to you with a BMI of more than 30. And what is the number one complaint that they will have? The number one complaint that they will have is that they will feel that there is as if something, a pervaginal mass that is coming out, right? They will have pelvic pressure or something that is protruding from the vagina. So pervaginal mass that's coming out. And if the pervaginal mass, for example, the uterus, if it comes down, right? We have different sorts of names for these things. We have cystocele, rectocele, right? So depending from where we had the prolapse. For example, if it comes down, even if it presses down on the urethra, then this can cause urinary incontinence. Or, for example, always remember this, that the wall of the bladder, right? Always remember this, that the wall of the bladder is very sensitive. So whenever something comes into contact with the wall of the bladder, even, for example, you will see that during severe constipation, sometimes when the large intestines, when they get severely dilated, and if for any reason they can cause some sort of a friction in between the tissues and the bladder, bladder irritation or stimulation will always result in contraction that will cause you to go to the bathroom frequently. So increase urinary frequency. So same way, if the uterus comes down and if it comes in contact with the bladder, this can cause severe urinary frequency. Also, if it presses down on the large intestines, then it can cause constipation. And obviously, for obvious reasons, if there's a pervaginal mass that's coming out through the vagina, then there will be severe dyspareunia, or we call this painful sexual intercourse, right? So sexual dysfunction, very, very high yield. Now, there are ways by which the uterus might come down. If it comes down from the anterior compartment, we usually call this cystocele, which is the most common, right? If it comes down to the posterior compartment through the rectum, we call this rectocele. Or if there's sometimes that the herniation could happen apically, and it can present to you as a bulge. So this is called apical compartment prolapse. That's not very high yield. For the most common one is cystocele, and the cystocele is the one from which the most amount of questions usually come from in the Usmle step 1. And if there is a cystocele, then there could be urinary incontinence or urinary frequency. That's number 1. If it's a rectocele, however, the symptoms will focus more on constipation and all of those things. So that's that. And there's another term that we call this. There's another term called uterine precedentia. Uterine precedentia is when we have all 3 compartments, that is anterior, posterior, and apical. When there's a total pelvic organ prolapse, when all the compartments, when there is herniation through all the compartments, we call this uterine precedentia. This is very, very rare and unlikely. Okay, what are some of the mechanisms which we can do? Have you guys heard of? So what we usually do is that we try to do manual replacement. We try to do manual repositioning of the uterus. And then after that, we can do some other things. That is, we can, have you guys heard of pessary? Yes or no? Have you guys heard of pessary? The answer is yes, right? So that's another procedure that we can do. Then can we also advise the females to have some sort of an exercise regime where they can strengthen their levator ani muscle? Yes or no? The answer is yes. Do we call them Kegel exercises? Yes or no? The answer is yes, right? So those are some of the things that we can do to prevent further prolapse. There's another thing, high yield over here, very quickly. Is there a possibility that there could be some females who has the pelvic organ prolapse for a long period of time, but they fail to address this to the physician? Yes or no? The answer is yes, right? In those patients, the exposed uterus, can they undergo friction? The answer is yes. So isn't there a possibility that we can get some sort of carcinoma in the exposed part of the uterus for long-term patients who have pelvic organ prolapse? The answer is also yes or no? The answer is yes. Okay. So these are some of the things that you need to understand. So why am I discussing these things? I'm discussing these things is because I want to make sure that you guys can properly link your pathologies, one pathology to another pathology. Okay, so that's it. Okay, now let's come down and let's talk about the female reproductive histology. Is everyone ready? Yes or no? Female reproductive epithelial histology. Is everyone ready? Okay. So let's talk about the female reproductive epithelial histology over here. So we have the vulva, vagina, ectocervix, transformation zone, endocervix, uterus, fallopian tubes, and the ovaries. So the way that they're discussing this is that from downwards to upwards, right? So for example, let's say that this is the uterine structure. Okay, so the first organ that we will encounter is the vulva. The vulva is the exposed part of the female reproductive system. Now, always remember this. Whenever we have exposure of a skin, that skin needs to have 2 properties. Exposed skins are more at risk of friction. Yes or no? Fast answer, please. The answer is yes. So if exposed skins are more risk at friction, should we have 1 layer of epithelium or should we have multiple layers? The answer is whenever we have an exposed skin, always remember this, that if 1 layer comes off due to friction, there should be another layer for protection. So always exposed skin is stratified, meaning that it's multiple. Another thing is exposed skin could be keratinized or could be non-keratinized. If it's keratinized, then there is keratinization, means that there is deposition of a protein called keratin that gives the skin an extra layer of protection, and it also gives a certain color to the skin. So the vulva is a part of the female reproductive organ that is exposed, but it's not keratinized. Then we have the vaginal portion, that is the same thing, that is exposed. Since it's exposed, it's at risk of friction. During, for example, sexual intercourse, there needs to be a stratified layer in the vagina and the vulva, and also there needs to be a stratified layer on the glans penis and the shaft of the penis. So that's why the difference is that in the vagina, there is stratification without keratinization, and in males, we have stratification with keratinization, as simple as that. Then the next portion is ectocervix, which is also at risk of friction. So that's also another reason that this is stratified but non-keratinized, right? Then the next one is the transformation zone. What is the transformation zone? The transformation zone is the zone of the female reproductive organ from which the epithelium lining it transforms from a squamous epithelium to a columnar epithelium. The answer is why. The answer is because columnar epithelium is more favorable for releasing, for example, secretions, or it's also responsible for maintaining a certain structure. So that's that. Always remember this: squamous epithelium will provide us with protection. Squamous epithelium in the blood linings will allow for proper movement of substances. And columnar epithelium and cuboidal epithelium, these are basically there for secretions and for maintenance, as simple as that. So transformation zone is when the female reproductive organ transforms from the squamous epithelium to the columnar epithelium so that it can secrete substances, and it can also make sure that there is proper maintenance of any other future substance, for example, future structure like a zygote, right? So squamocolumnar zone is the zone where they transform. And this is the area from where we usually take our sample for pap smears. Very, very high yield. Next one is endocervix. Endocervix is, once again, simple columnar because it's not at risk of friction. Uterus is also simple columnar with glands, okay, with long tubular glands or coil glands. Fallopian tube is obviously columnar with cilia because fallopian tubes are responsible for moving the ovum from the ovaries all the way to the ampulla. Okay, so that's that. Next one is the ovaries. Ovaries are cuboidal. Always remember this. Ovaries are cuboidal. So I think that this does not need any other explanation except which ones are very important, which ones are not important. Obviously, the transformation zone is one of the most important histology. Uterus is a very important histology. Ovaries are important. Fallopian tubes are important. Okay, so these are very, very important. Are we clear? Yes or no? Yes. Now, the next one that I want to talk about is, let's talk about the male reproductive system. There's nothing over here that we are already not aware of. So there's no point in explaining this diagram. We are all aware of the different structures of the male reproductive system. This is a cross section of the corpus, right? The shaft of the penis. And as you can see in a cross section, this is also not very important, but just for understanding purposes, because for example, let's say in the future, you receive a question, how do you know where do we have most of the important structures? So let's just discuss this very quickly. This is a cross section of the shaft of the penis. So always remember this, that the urethra from where we urinate, the urethra is always at the downward portion, right? It makes sense because if the urethra was at the exposed part or the superior portion of the penis, then would it be more at risk of getting injured? Yes or no? The answer is yes, right? So for protection of the urethra is placed downwardly. Then over here, you have the corpus, you have the corpus cavernosa, and you have the bilateral deep arteries. What's important is this, it's this one, that in the middle, you have a vein. This is called deep dorsal vein. And then you have arteries. The arteries are called dorsal arteries on each side, and you have a dorsal nerve. So dorsal vein, dorsal artery, dorsal nerve. So laterally, you have the nerve, and medially, you have the vein. In the middle, you have the arteries. Okay, so that's it. And this one on the top, this is called the superficial dorsal vein, as simple as that. Okay, so these are very, very high yield, especially of which ones are arteries, which ones are veins, so that in the future, if you receive a question, you're more aware. And there's another thing that I want you to remember very quickly, that is the flow of, or what are the structures through which we have sperm ejaculations. Number one, sperms are usually formed in the seminiferous tubules. After they are formed, they move up through the epididymis, then to the duct deferens, then they go to the ejaculatory duct. Through the ejaculatory duct, you have the sperm that's coming out to the urethra, and then we have the ejection. Ejection is through the glans penis, as simple as that. Very quickly, over here, sperm ejaculation. Is this a sympathetic response, or is this a parasympathetic response? Last answer, please. Sympathetic or parasympathetic? Sympathetic, very good. Next one, penile erection. Is this a sympathetic or a parasympathetic response? Parasympathetic, very good. Then sperm ejection. What is ejection? Ejection is the speed at which the sperm comes out. The speed at the ejection speed of the sperm is directly responsible for your conception. Ejection is sympathetic, parasympathetic, or somatic? Which one? Fast answers, please. Sympathetic, parasympathetic, or somatic? Which one? The answer is somatic. Very good. Ejection is dependent on pudendal nerve. Always remember this. Ejection is somatic. Okay. So that's it. Did we understand all of this information over here? Yes or no? Did we understand all of this information over here? Yes or no? Yes. Okay. The quick questions and quick answers. Number one, left side or right side? Which side is more at risk of developing a varicocele? Fast answers, please. Very good. Over here, which gonadal vein drains into the renal vein? Which gonadal vein drains into the renal vein? Left renal vein. Very good. What is the name of the ligament that will connect the ovaries laterally to the pelvic wall? What is the name of the ligament that will connect ovaries medially to the uterine wall? What is the name of the ligament that will connect the cervix to the lateral wall? Very good. What is the name of the ligament that will connect the uterus, fallopian tube, and ovaries to the lateral wall? What is the name of the ligament that will connect the uterus anteriorly to the labia majora? What is the ligament that we usually ligate in a hysterectomy? Hysterectomy, cardinal. What is the ligament that we usually try to repair in an ovarian torsion? Okay. Next one. What is the epithelial layer of the ovaries? Cuboidal. What is the epithelial layer of the fallopian tube? Okay. This is columnar epithelium. Okay. Very good. Now, I want to discuss another thing over here very quickly. Just give me 1 second. Okay. So I want to talk about a very high yield question that is a Usmle favorite. So when I talk about Usmle favorite, I mean that there's a higher possibility you will receive at least one question in your exam regarding urethral injury. Okay. Are we ready? Yes or no? Okay. Okay, good. So let me just draw up the structure very quickly over here. Okay. So let's say that this is the urethra. Okay. This is the corpus. Wait 1 second. This is the urethra. This is the corpus. Okay. You have the glans penis over here. This is the lower portion over here. Okay. And over here, let's say that you have the testis. Okay. And over here, let's say that you have the bladder. This is the bladder. This is the testis. This is the red line of the urethra. The black box is the glans. Okay. And obviously the urethra is coming from the bladder. Okay. So that's it. Okay. Now let's talk about urethral injury. What do we mean by urethral injury? First of all, before we understand urethral injury, I just want to talk to you about the types or the types of urethra very quickly. Just give me 1 second. Okay. Give me 1 quick second. Okay, good. So over here, just want you guys to very quickly notice the urethra over here, right? As you can see that this is the urethra. The urethra that we usually have over here, this is called the membranous urethra, right? Then what are the other types of the urethra that we can have? The urethra that we can have, another one that's called the spongy urethra. The spongy urethra is usually the one that is covered in both layers by the cavernosomes. So, and you have the membranous urethra that's over here. This membranous urethra is usually is usually engulfed by the prostate glands. So that's that. So membranous and the bulbous, or the spongy urethra. So depending on this, we have two types of injury that usually happens. So one type of injury is when, for example, you have a patient who, for example, let's say that this is a pole and the patient falls on the pole like this, right? So let's say that the pole is directly in between the two legs of the patient. And if it hits the patient like this, or if there's any sort of a hit, for example, let's say that someone kicks someone in between their legs, what is the type of urethral injury that is more common? The answer is that the type of urethral injury that is more common in these type of damages or injuries is that the bulbous urethra, that we have the damage of the bulbous urethra. Now the question is that, let's say that this is the scrotum. Okay, let's say that this is the scrotum. If we have a bulbous or a bulbar urethral damage, right? For example, let's say that in a bulbar urethral damage, what happens is you have the urethra that gets broken off, or that gets disconnected. If the urethra gets disconnected like this, can we have accumulation of blood in the corpus? Yes or no? The answer is yes. As a result, can we have swelling of the corpus? Okay, good. Can we have accumulation of blood in the scrotum? Yes or no? The answer is yes. Can we have swelling of the scrotum? Yes. Yes or no? The answer is yes. And also, if there's swelling of the scrotum, at one point with all the accumulated blood in the scrotum, can we have, for example, can we have blood at the urethra, blood at the meatus? Yes or no? Blood that's coming out through this way? The answer is yes. Okay, so as simple as that. So that's one sort of a urethral injury. What is another sort of a urethral injury? The another sort of urethral injury that can happen is that, for example, let's say that there is a patient who has undergone a car accident. After they have undergone a car accident, they have fracture of their pelvis. If they fracture their pelvis, right, the pelvic organs, for example, let's say a piece of the pelvic bone comes and they directly hit the urethra like this. Can we have damage of the upper portion of the urethra? The answer is yes. The question is, why do we not get damage of the lower portion of the urethra? That's because the lower portion of the urethra is covered by the corpus cavernosum. So there is a very low chance that a pelvic fracture can cause an anterior urethral injury. Most of the time, a pelvic fracture will cause a posterior urethral injury or a membranous urethral injury. Now the question is, if there is a membranous urethral injury, can we have blood accumulating up over here around the bladder? Yes or no? The answer is yes. If the blood accumulates around the bladder, can we have the bladder moving up? Yes or no? The answer is yes. And also, when the bladder moves up, the prostate, can it also move up? Yes or no? Because of all the blood that's being accumulated over here? The answer is yes. Okay. And along with this, we can also have blood coming out through the penis or blood at the penile meatus. But do we have scrotal hematoma or swelling of the corpus cavernosum? The answer is no. Okay. So quickly, two very quick questions over here. If you have a patient who comes to you with a history of a trauma, you're not sure what sort of trauma this is, but you see scrotal hematoma, you see penile swelling, and in this case, which urethra is damaged, anterior or posterior? Fast answer, please. Anterior, very good. What sort of a trauma do you think this is? Is this a perineal injury? Or is this a straddle injury, or is this a pelvic fracture? The answer is, this is a straddle injury or a pelvic fracture. Which one? Straddle injury. Let's say there's another patient who comes to you after getting involved in a car accident. And now the patient comes to you with a high riding prostate, pain, and blood at the meatus. What sort of injury is this, anterior or posterior? The answer is, this is posterior. Very good. Okay. So that's it. In your Usmle step 1, they will give you something like this. Okay, look. So this is basically the urethras. The first one that is over here in the prostate, this is called the prostatic urethra. The one that's leaving the prostate, that's called membranous. Then you have the bulbar, then you have the penile. Okay. The way that your Usmle step 1 will give you the question is, they will give you, instead of this, they will have arrows that are pointing like this. And over here, they will say A, B, C, and D. And then they will describe a situation. For example, let's say if I say pelvic fracture, and let's say this is A, B, C, and D. If I say pelvic fracture, which one, A, B, C, or D, which one will be damaged? D, very good. Next one is, if I say straddle injury, A, B, C, or D, which one will be damaged? Fast answers, please. C, right? As simple as that. So do you guys understand the way in which the question will be structured? Yes or no? Answer is? The answer is yes. Okay. So let's talk about genitourinary trauma, which we have just discussed. We discussed urethral injury. So that's that. Okay. Always remember this, that in a urethral injury, never catheterize the patient. Urethral catheterization is contraindicated. Usually we go for suprapubic catheterization, right? And over here, the signs, symptoms, and the clinical features and everything else, I have discussed this, and this is very important. So remember that. Also remember that the urethra in between the prostate is called the prostatic urethra. Over here, this is called membranous. This is bulbous, and this is penile. Okay, so that's it. Next one is bladder injury. Bladder injury will present to you with hematuria, suprapubic pain, right? And there are 2 types of bladder injury. There could be an superior wall bladder injury or an anterior bladder injury. Superior wall bladder injury is usually that we see, for example, in a seat belt trauma, right? For example, let's say that the seat belt is wrapping around the anterior portion of the abdomen, and a sudden cessation of the car can put pressure by the seat belt on the bladder, which can cause superior bladder trauma. And pelvic fracture usually causes anterior bladder trauma. So that's it. Now, over here, there's not really a lot of questions you get for bladder injury, but the signs, symptoms, and the clinical features are usually going to be the same. So patients, they will have difficulty in getting rid of the urine. So there could be intraperitoneal urine accumulation that can increase the creatinine and everything else. And some patients can also have extraperitoneal urine accumulation in the retropubic space. Okay, so that's it. Renal injuries are also not very high yield. Renal injuries are usually if someone gets a traumatic injury in the back, for example, specifically around the 12th rib. Then it will present with bruise, flank pain, hematuria. Who does that? Okay, so that's all we need to know from genitourinary trauma. Urethral injury, one more time, is the most important one. Now let's move down to autonomic innervation of male sexual response. I've already talked about this. You have 3 phases of sexual response in a male. You have erection, emission, expulsion, or erection, ejaculation, ejection, the same thing. Erection is a parasympathetic response. So S234 is responsible for this. If there is a male who has a traumatic injury to the lower sacral nerve, then there's a possibility that they can be impotent, for example. Then they can have erectile dysfunctions. So that's it. So we usually know that the sympathetic supply results in more blood flow. So in order for blood flow to happen, there has to be vasodilatation. And the number 1 mediator of vasodilatation is nitric oxide, which we usually get from. Can anyone tell me from which amino acid do we usually get nitric oxide very quickly? Let's see if anyone knows. Which amino acid is responsible for giving us nitric oxide? Arginine. Very good. Very good. Arginine. Okay. Arginine is responsible for giving you nitric oxide, which increases the CGMP, and this causes smooth muscle relaxation. Then the next one is emission. That's a sympathetic. That's a sympathetic response that we usually get from hypogastric nerve. That's from the thoracic 11 to the lumbar 2. And the next one is expulsion. Expulsion is by pudendal nerve. So that's it. So you need to remember which one is what. So one more time: erection P, emission S, expulsion pudendal. As simple as that. Okay, now let's move forward to the structure of the seminiferous tubule. Is everyone ready? Yes or no? Fast answers, please. Okay, good. Now let's talk about the structure. So over here, what is this structure of? Fast answers, please. This is the structure of the. This is the structure of the seminiferous tubules. Okay. So the seminiferous tubules, as you can see, they are lined together by these totipotent cells. So the seminiferous tubules, all as a whole. Okay, let me just draw this diagram over here so that you can understand this. It's important. I'm going to tell you why. So we are drawing these seminiferous tubules, which is shaped like a circle, like this. Okay, and this circle over here. Okay, they have a lot of cells like this. You have you have the big cells like this. Then you have some small cells. Then you have some smaller cells. Okay, and this goes round and round. So something like this. Okay. 1 second. Okay. And okay. So these are your cells. Now, what are these cells? These cells are the big ones. They're usually called spermatogonium. Spermatogonium. The ones that are inside over here, they're called spermatocyte. The ones that are here, they're called spermatids. And the ones that are released in the tubule, they're called spermatozooms. So spermatogonium, spermatocytes, spermatids, and spermatozooms. So that's that. And you have two types of very high yield cells. What are the names of these cells? The names of these cells are Sertoli cells and your Leydig cells. So your Leydig cells, always remember this, that the Leydig cells, they will stay outside of the seminiferous tubules. The way that you can remember this is that L for Leydig, L for late. If you're late, are you allowed to enter? Yes or no? The answer is no. So since Leydig cells are late, they cannot enter, so they stay outside. And the ones that are inside are the Sertoli cells. They're all over. Sertoli cells. Now we have the. So before I go any further, did you guys understand the structure of the seminiferous tubules? Yes or no? Last answers, please. So this is the seminiferous tubules. You have spermatogonium, spermatocytes, spermatids, spermatozoon. And then from the seminiferous tubules, they go to the epididymis, ejaculatory duct. Okay. And then the vas deferens and everywhere else. Okay. So that's that. Now, the thing is, you have two other cells. You have the Leydig cells and the Sertoli cells. One more time, Leydig cells are late, so they stay outside. And the Sertoli cells, they stay inside. As simple as that. Now, let's talk about the hypothalamo-pituitary ovarian axis. The hypothalamus is stimulating the pituitary gland by gonadotropin releasing hormone. That the gonadotropin releasing hormone is stimulating the release of two hormones, LH and FSH. LH will work where? Fast answers, please. LH will work in the Leydig cells. Yes or no? Luteinizing hormone will stimulate the Leydig cells to release what? Fast answers, please. They will stimulate the Leydig cells to secrete testosterone. Very good. This testosterone, in turn, will stimulate the spermatogonium to increase their synthesis of sperm. So that's that. Another one is that FSH, the follicle stimulating hormone, they will stimulate the Sertoli cells. And once they stimulate the Sertoli cells, the Sertoli cells what will they do? They will secrete inhibin. Yes or no? Fast answers, please. They will secrete inhibin. So this inhibin will inhibit the follicular stimulating hormone to maintain what? Homeostasis. Are we clear, guys? Yes or no? Fast answers, please. Yes. Okay. So that's that. So the seminiferous tubules, you have the spermatogonia, which maintains the germ cells. Sertoli cells, they secrete inhibin, which inhibits follicle stimulating hormone. They also secrete androgen binding protein, and they produces Mullerian inhibiting factor. So we are all aware of this. Tight junctions between the Sertoli cells from the blood testis barrier. Please underline this line. All the tight junctions over here, this blue line, I mean, this blue color over here in the seminiferous tubules, they represent the extremely tight junctions in between the cells. The junctions are so tight that you cannot identify one cell from another. They appear as one single color because that's how tight they are kept. So tight junctions between the Sertoli cells forms the blood testis barrier. Very important. Next one is that the blood testis, that the Sertoli cells, they regulate spermatogenesis and they are very temperature sensitive, as simple as that. So that's why, since they are temperature sensitive, usually in varicoceles, if we do not treat the varicocele, then we can have crypto or chiasm or infertility or something like that. Then the next one is Leydig cells. They're responsible for secretion of testosterone in the presence of LH. Testosterone production is unaffected by temperature. Sertoli cells, however, are temperature sensitive, very important. And Sertoli cells forms the tight junction in the seminiferous tubules by the blood testis barrier. So that's also very important. Okay. Did we understand the seminiferous tubules? Yes or no? Fast answers, please. Did we understand the seminiferous tubules? Yes or no? Okay. So which cell stays inside the seminiferous tubule? Sertoli cell or Leydig cell? Fast answers, please. Which cell stays outside? Sertoli cells or Leydig cells? Leydig cells. Which cell forms the blood testis barrier? Sertoli cells. Very good. Which cell is more temperature sensitive? Sertoli cells. Very good. Which one regulates spermatogenesis? Sertoli cells or Leydig cells? Sertoli cells. Okay. Okay. So with that being said, we are done with reproductive anatomy. Okay. Now, before we begin reproductive physiology, let's take a short 5-minute break. Yes or no? Fast answer, please. Okay, let's take a short 5-minute break and then let's begin. Did we understand the topics? Yes or no? That we have discussed today? Okay. How many of our students from this batch will start the evening batch today? Okay. So who received the email? Dr. Tahira, I think you have received the email. And who hasn't? Okay. Okay. Okay, so that's that. Thank you so much. Let's take a break for 5 minutes and then let's begin. Okay, can everyone hear my voice? Yes or no? Is everyone back from their break? Okay, is everyone back from their break? Yes or no? Yes. Okay, good. Just give me 1 second. Okay. No. Okay, so one more time. Do I have everyone's attention? Can everyone hear my voice? Yes or no? Okay, so let's begin. So right now we are discussing reproductive physiology. So reproductive physiology is basically going to talk about all the different sorts of physiological processes that are happening in our reproductive system. So let's talk about the first physiological process, that is spermatogenesis, or the synthesis of sperms, right? So one more time, spermatosynthesis or spermatogenesis, where does this happen? The answer is it happens in the seminiferous tubules, right? This begins with puberty at spermatogonia, then full development takes 2 months. It occurs in the seminiferous tubules. It produces spermatids, which we know, and then it undergoes spermiogenesis, which is the loss of the cytoplasmic contents, gain of the cap, and formation of the mature spermatozoa. The steps of spermiogenesis, that is loss of the cytoplasmic content, gain of the cap, meaning they form a cap and they lose their cytoplasmic content to form a mature spermatozoa. This is very important. Okay, so that's that. Then over here, sometimes the tail of the sperm is basically, it's a ciliary movement. So we can have ciliary dyskinesia, especially in primary ciliary dyskinesia, we call this Carter-Jenner syndrome. And sometimes we can also have ciliary abnormality in cystic fibrosis. So that's that. So tail mobility is impaired in primary ciliary dyskinesia. Tail mobility is normal in cystic fibrosis, but we get infertility in both of these diseases. The difference is in primary ciliary dyskinesia, we get an infertility because the tails will not move. And in cystic fibrosis, we get infertility because of thick secretions. Why do we get thick secretions in cystic fibrosis? Can anyone tell me very quickly? Cystic fibrosis is a genetic disorder where we get uh, uh, an abnormality of a gene called CFTR gene that's located on chromosome number 7, right? That's located on the chromosome number 7. CFTR gene is responsible for the synthesis of chloride channels. So since this gene is non-functional, the chloride channels will not be produced. As a result, secretions will have a lot of chloride in them. So if they have a lot of chloride in them, what happens is that this causes the osmolarity of the secretions to be very high, which in turn produces very thick and viscid mucus. And especially the sperm also is a sort of secretion. So in the sperm, the chloride content is very high in cystic fibrosis. So that's why they cannot come out very properly. And that's why we get infertility. Okay, so that's it. Next is, let's talk about some hormones over here very quickly. Let's talk about the first high yield female hormone, that is estrogen. This is the ovaries, for example. This is an ovarian follicle. So if you take a small section of the ovarian follicle, and if you visualize this over here, then what will you see? If you take a small section of the ovarian follicle, the ovaries, they're lined like this. They have layers. The outer layer is called the thicker layer. The inner layer is called the granulosa layer. This is called the thicker layer. This is called the granulosa layer. So the thicker layer is responsible for having the receptor for luteinizing hormone. So the outside layer has the luteinizing hormone receptor. So the luteinizing hormone will come. They will induce a CAMP mechanism, because do you guys remember from our endocrinology discussion that luteinizing hormone falls in flat champ, yes or no? FSH, LH, ACTH, TSH, everything that works by CAMP mechanism Do you guys remember the names of the hormones for the second messenger system? Yes or no? Flat champ, GOTAG, right? The nitric oxide, EDRF, ANP, BNP. Do you guys remember that or not? Yes or no? Fast answers, please. Yes or no? Who remembers this? The second messenger system hormone, the second messenger system. In endocrinology, who did endocrinology with us? Endocrinology, who has done endocrinology with us? Okay. Yeah. You have done endocrinology, Dr. VK, and you do not remember from where you have the FSH, LH, ACTH, CAMP from the second messenger system. I have placed a lot of emphasis on the importance of this. So let me just talk about this very quickly. One second. Are you sure that you guys do not remember from where we have the secretions? The FSH, LH, ACTH, TSH, the second messenger systems? Yes. So this should be somewhere over here in this lecture. So if you guys want, please go back to this lecture and try to remember where we have talked about this. This should be somewhere over here. Okay. So basically what I'm trying to put emphasis on is that FSH, LH, ACTH, these are all hormones that will induce the CAMP mechanism. Yes or no? For example, if I talk about oxytocin, GnRH, which secondary messenger system do they induce? Fast answers, please. Secondary messenger system by GnRH, oxytocin. Very good, IP3 DAG. If I talk about ANP, BNP, nitric oxide, which one will they induce? Fast answers, please. CGMP, very good. If I talk about insulin, which one will they induce? Fast answers, please. Insulin, tyrosine kinase receptor. Okay, so that's what I'm trying to talk about. So so in the ovaries, you have two layers. You have the outer theca layer and the inner granulosa layer. The theca layer, they have the receptors for luteinizing hormones. So whenever the luteinizing hormone, they bind to the receptor, and then they cause the release of the second messenger system, CAMP. So CAMP in the luteinizing hormone, what it does is that it converts cholesterol. As you can see that the CAMP, what it does is that it converts the cholesterol to androstenedione, right? So this androstenedione in turn will move from the theca interna to the granulosa cell. And in the granulosa cell, under the influence of FSH, so the granulosa cell has the receptor for FSH, and the theca cell has the receptor for the LH. So the FSH will come to the granulosa cell, and the FSH will also induce a CAMP mechanism, which will convert androstenedione to estron, and estron will be converted to estrogen, as simple as that. So very quickly, there are two types of questions. LH receptors are in which cell, theca cells or granulosa cell? The answer is LH receptors are in the theca cell. FSH are in which cells, theca cells or granulosa cell? The answer is FSH is in the granulosa cells. Then, which substance will move from LH to from theca cell to granulosa cell? The answer is androstenedione. Okay, androstenedione will move from the theca cell to the granulosa cell. As simple as that. So the estrogen, the source is from the ovaries. We can also get estrogen from the placenta and the adipose tissue. Always remember this, adipose tissues, they have aromatase enzyme. Adipose tissues have aromatase enzyme. So if someone has a lot, for example, if there's a female who is very morbidly obese, do they have a lot of estrogen? The answer is yes. Are they at risk of developing endometrial cancer because of that estrogen? The answer is yes. Okay, so that's it. Next one is function. Function of estrogen is very simple. That is development of the female secondary sexual characteristics, growth of the follicles and the myometrium, excitability happens under estrogen, upregulation of estrogen, LH, and progesterone receptors, feedback inhibition of FSH and LH, everything happens. So these are not very high yield discussions. You guys already know what estrogen does. So let me talk about the clinical aspect of this, that in pregnancy, you have increase of estrogen by 50-fold. And estrogen receptors are expressed in cytoplasm. They translocate to the nucleus when bound by the estrogens. Always remember this, estrogen receptors are steroid receptors, right? So they're expressed in the cytoplasm. And whenever we have estrogen that binds to the receptor, we have a hormone receptor complex. This hormone receptor complex usually works in case of a steroid hormone, what they do is that this hormone receptor complex, do they directly go to the nucleus and induce transcription, translation? Yes or no? The answer is yes. Okay, that's something like that. So that's that. The source of the estrogen, one more time, is important. So please remember that. The the theca and the granulosa cells are very important. So please remember that. And always remember that estrogen receptors are expressed in the cytoplasm. That's also very high yield. Okay. Next one is progesterone. Progesterone source is very important. Progesterone is used for the maintenance of the luteal phase, right? So what is the luteal phase? The luteal phase is basically the phase where the uterus is ready for implantation, right? The uterus, they increase in their size, the blood supply increases, the glandular amount of the uterus for secretions of different sorts of substance, even they increase. And do we get menstruation when there's a sudden cessation of progesterone? Yes or no? The answer is yes. So progesterone, if there is no progesterone all of a sudden, then females experience menstruation. So the thing is, if there was a continuous supply of progesterone, will we always have a luteal phase in the pregnancy? The answer is yes. So the next question is progesterone important for the maintenance of pregnancy? The answer is absolutely yes. Okay. So that's that. So progesterone initially is released from the corpus luteum of pregnancy. Then later at one point when the corpus luteum of pregnancy involutes, then we have progesterone secretion from the placenta, adrenal cortex, right? So that's that. And also in males, we get a little bit of progesterone from the testis. So they maintain the luteal phase and they prepare the uterus for implantation. Their functions are very simple. They will cause stimulation of the endometrium. They will cause production of the thick cervical mucus to inhibit sperm entry into the uterus so that, for example, if there is a female who's already preparing their uterus for implantation of a fetus, is it important to prevent any further entry of sperm into the uterus physiologically? Yes or no? The answer is yes, right? Because if there is a female uterus that is preparing itself for an environment to grow a fetus, then it needs to inhibit any further process of fertilization. So that's why progesterone is important. Can we also use this function of progesterone to use this as a contraceptive method? Yes or no? The answer is yes. Okay, so that's it. Next one is prevention of endometrial hyperplasia, very important. Progesterone increases the body temperature, and this decreases estrogen and gonadotropins, if that makes sense. During pregnancy, progesterone is important for maintenance of pregnancy, decrease excitability, and decrease prolactin action on the breast. Not important, but we are aware of this, so let's move on. And this is important. How do we get lactation? Lactation is when we get fall in estrogen and progesterone after delivery. So after delivery, the progesterone level fails. Since progesterone level fails, as you can see, increase of progesterone will decrease your prolactin. So after pregnancy, when progesterone falls, can we have increase of prolactin? Yes or no? The answer is yes. So after pregnancy, when progesterone falls, we have increased action of prolactin on the breast that causes lactation. Are we clear, guys? Yes or no? Fast answers, please. Yes. Okay, good. Can you guys just give me 1 second, please, very quickly? Give me 1 second. Okay. So are we clear, guys? Yes or no? Estrogen, progesterone. Okay. Okay. Is everyone ready to talk about oogenesis? Okay. So oogenesis. What is oogenesis? First and foremost, the number one thing that I want to bring to everyone's attention is that females, do they only have a limited amount of ovum supply throughout their entire life? Yes or no? The answer is yes. That means that after a certain age, is there a possibility that there is no way a female can get pregnant? The answer is yes. On another contrast, a male, can they produce sperm throughout their whole life? Yes or no? The answer is yes. Okay. So that's very important. Now, why am I talking about this? I'm talking about this because there is a very high yield disease that's associated with this. Can we get a disease called ovarian insufficiency? Yes or no? Primary ovarian insufficiency. The answer is yes. What is primary ovarian insufficiency? Primary ovarian insufficiency is basically a disease or a condition where we get early depletion of all the ovums in a female. Yes. So for example, let's say that by the age 40, 41, if the female gets rid of all the limited supply of ovum, can they get pregnant? The answer is no. Okay, so this is called premature ovarian failure or primary ovarian insufficiency. Are we clear, guys? Yes or no? Okay, okay. So oogenesis. What is oogenesis? Oogenesis is basically the development of the ovum from an oogonium. So primary oocytes, they begin in meiosis 1 during fetal life, and they complete meiosis 1 just prior to ovulation. This is very, very important. The first one is that first and foremost, you have the diploid oogonium that forms the primary oocyte. Then from this primary oocyte, this is where there's an arrest in development. So always remember this. This is a question in your step 1 exam. That is, prior to ovulation, at which stage does an ovum stay? At which stage does the female sex cell stay? The answer is in meiosis 1. Okay, and right after they complete their ovulation, they have meiosis 2. So meiosis 1 is arrested in prophase 1, and meiosis 2 is arrested in metaphase 2 until fertilization. So one more time, before ovulation, what is the stage? The stage is meiosis 1. Yes or no? Fast answers, please. Right after ovulation, have they completed meiosis 2? The answer is yes. And after fertilization, which process is completed after fertilization? The process that's completed is metaphase 2 of meiosis 2. Okay, so that's that. So please remember that. That could be a question in your step 1. It's not a question yet. I feel like there's a possibility this could be one question. Okay, so that's that. Next one is ovulation. What is ovulation? Ovulation is when we have the release of the ovum from the ovaries, right? When does this happen? This usually happens on the 14th day of the last menstrual cycle. Yes or no? For example, let's say that the menstruation of a female, it ends in the January 31st of this month. Then can we expect ovulation to happen in February 12th or February 13th, which could be a tentative date? Yes or no? The answer is yes or no? The 14th day of the last menstrual period. One more time. If menstruation of a female ends on the January 31st, what is the expected date of ovulation for that female? Fast answers, please. Can we get some fast answers, please? Because we do not have a lot of time. I want to finish. Thank you so much. 14 days. So can we expect that date to be 14th of February? Yes or no, for example, if it ends on the January 31st? If it is a 28-day cycle, yes. But tentative in a normal female with a normal menstrual cycle, when do you think the ovulation date is? Isn't it at the 14th day of the last menstrual period? Yes or no? Fast answer, please. Yes. Okay, good. So why do we get this? Because all of a sudden there's a sudden increase in estrogen, increase of GnRH receptor on the anterior pituitary. This sudden release of estrogen, this was supposed to decrease the luteinizing hormone, but what it does is that estrogen turns from inducing a negative feedback to a positive feedback. And these release of estrogen, what it does is it stimulates the hypothalamus to secrete more. It stimulates the anterior pituitary to stimulate. The estrogen that is released, it stimulates the anterior pituitary to release more LH. Right? Usually, what happens is that there's a negative feedback, but during ovulation, this negative feedback turns into a positive feedback. So the estrogen now works on the anterior pituitary to release more luteinizing hormone, which in turn releases more estrogen. So there's a sudden surge of luteinizing hormone and estrogen. This sudden surge of luteinizing hormone and estrogen results in the release of the ovum from the ovaries. So this is called the rupture of the follicle. So we have a Graafian follicle from where the ovum is released. After the ovum is released, the remnant portion of the Graafian follicle, does it form the corpus luteum? Yes or no? Fast answers, please. The answer is yes. Okay, as simple as that. Now, some females, can they experience pain when the ovum is released from the Graafian follicle? The answer is yes. This is called ovulatory pain or mid-cycle pain, which is known as Mittelschmer's disease. This is very similar. The pain sometimes can be so excessive that this can mimic an appendicitis pain, right? And sometimes this can cause some amount of peritoneal irritation. So it's actually not a very fatal disease, or it's actually not a very serious disease over here, because this is a physiological process. This is not a pathology. The only problem is that during the release of the ovary, of the ovum from the Graafian follicle, we have a little bit of pain, which the females experience. So this is completely normal. So we usually manage this with pain medications and everything else. So but it's important that we differentiate Mittelschmer's disease from acute appendicitis. So that's that. So how do we do this? We can do this based on clinical features or ultrasonogram findings or imaging. So that's that. Okay. Next one is increase of temperature. Increase of temperature is usually due to progesterone. So that's it. Okay. Next one is, let's talk about the menstrual cycle over here very quickly. So the menstrual cycle, as you can see, is under the influence of GnRH that is being secreted from the hypothalamus. They will work on the anterior pituitary to secrete FSH and LH. This diagram is very important, especially this graph. This graph shows that LH stays normal, but all of a sudden in the mid-cycle of ovulatory period, there's a sudden change in the estrogen feedback mechanism, which results in a excessive release of LH. This excessive surge of LH is known as LH surge. And this is represented by the blue diagram and the red diagram of mine on top of the blue diagram. And in your exam, they will ask you to name which hormone is responsible for this, which hormone is responsible for this. So when they do that, I need you guys to make the correct answers. So that's that. Next one is what happens. So whenever you have the release of FSH, this releases the primordial follicles, which forms the Graafian follicle. And under the influence of LH and estrogen, the release of the ovum happens from the Graafian follicle. The remnant is known as corpus luteum that secretes more progesterone. So what happens is, initially you have a menstrual period. And then after the menstrual period, under the influence of FSH, LH, and estrogen, especially progesterone, you have the proliferative phase of the uterus. That is, the uterus is preparing itself for implantation. And when the corpus luteum is responsible for the release of the progesterone, and then suddenly when there is no conception or fertilization, the corpus luteum, it degenerates. From corpus luteum of pregnancy, from corpus luteum, it becomes corpus albicans, and it degenerates, and there's a sudden cessation, there's a sudden fall of progesterone, as you can see. This sudden fall of progesterone, what it does is, it causes breakdown of the uterine wall, which was thickened and which was filled up with blood by the progesterone. So when it's not there, the uterine wall, it starts to shed off and it starts to involute. And that's when females, they experience the normal physiological process of menstruation, as simple as that. So I need you guys to put some attention over here to the diagrams. So these are the two diagrams that are very important. One is this diagram, another one is this diagram. Okay. So estrogen, always remember, there will be a sudden surge of estrogen in the middle, which will coincide with the LH surge. And then the progesterone will all of a sudden fall and then induce menstruation, as simple as that. So that's that. So the follicular phase can fluctuate in length. The follicular growth is fastest during the second week. Luteal phase is fixed for 14 days, after which menstruation happens, right? Then you have the estrogen that will stimulate endometrial proliferation, right? As this is the proliferative phase. This is on estrogen. This is the secretory phase. This is based on progesterone. So that's that. And progesterone will maintain the endometrium to support implantation. So this is during the secretory phase. A sudden fall in progesterone will cause menstruation. So that's that. And if there is a patient who has no progesterone, then fertility will also decrease. Have I made myself clear? Yes or no? Fast answers, please. Okay. Over here, A, B. A is for which hormone? Fast answer, please. LH. A, B. A is for which hormone? Fast answers, please. Estrogen. There you go. Okay, that was my goal for the last page. Now let's move forward to abnormal uterine bleeding. Is everyone ready? Yes or no? Fast answers, please. Do you guys want to take a 15-minute break before we move on with the with the lecture? Yes or no? Yeah. So let's take a break for 15 minutes and then let's come back. Thank you so much. Okay, is everyone back from their break? Can you guys hear my voice? Yes or no? Is everyone back from their break? Can you guys hear my voice? Yes. Okay, just give me 1 second, please. Let me just wait for this page to load up very quickly. So far, did you guys understand all the topics which we have discussed? Yes or no? That's answers, please. Yes. No. Okay. So are we ready to begin abnormal uterine bleeding? So let's begin with abnormal uterine bleeding. What do we mean by abnormal uterine bleeding? Uterine bleeding normally should be in a certain amount, and it should always happen in a certain pattern, right? That is, it should last with a moderate amount or a normal to moderate amount of bleeding, which should last for 3 to 5 days or close to 5 to 7 days at max. And there should be a proper pattern. That is, normal menstruation should happen at every 28 days cycle, for example. If there's anything abnormal, then that must mean that, first of all, the flow is either very high, yes or no, that there's excessive bleeding. That's number one. Number two is that there could be an irregular pattern of bleeding. So number one, this is characterized as heavy menstrual bleeding. Number two is there could be intermenstrual bleeding pattern without that. These are further subcategorized according to their causes. So there could be structural problems or non-structural problems. Structural problem means that there could be pathologies associated with the structure of the uterus. That is, in the uterus, we can get what? We can get certain problems. For example, we can get a polyp in the uterus. We can get some sort of malignancy in the uterus. We can also get fibroids in the uterus, submucosal fibroids, or we can get uterine hyperplasia, or we can get adenomyosis, that is endometrial glands in the myometrium. Yes or no? So these are some of the very high yield causes of uterine. These are some of the very high yield causes of uterine bleeding. There are some non-structural causes of uterine bleeding where if there's something wrong with the bleeding coagulation during ovulation or endometrial iatrogenic, these are some of the other causes. So did we understand this? Yes or no? This is just a description of abnormal uterine bleeding and why we have abnormal uterine bleeding. Very quickly, I just want to point out a couple of things very, very quickly. If you have a female who has an irregular shape of the uterus, okay, can I get the help of one physician who can help me out with some of these answers? Please write me in the chat box very quickly. All you have to do is just tell me the answer. One physician, please write me in the chat box to answer some gynecological questions very quickly. Okay. The reason why I asked you guys to actively participate in the class is because I want to aware you guys that Usmle is not only a test of your skills of how much medical information you know or you can attend. It's also a test of how well you can speak and converse with other physicians. So I believe that you guys can use this tutoring platform to use this to fix any issues that you can have for proper vocal conversations. So that's that. So Dr. VK, thank you so much for helping us out.
Yes, doctor.
Now, very quickly, if you have a female who comes to you with irregular shape of uterus, abnormal bleeding in terms of menorrhagia, excessive bleeding, and it's an obese female with early menarche, what is your most probable diagnosis for this type of bleeding?
Fibroid. It's a leiomyoma.
Okay, very good. Let's say you have another sort of a pathology where you have a female who comes to you with enlarged, retroverted, boggy uterus and excessive uterine bleeding. but the enlargement of the uterus is more or less uniformed. What is your diagnosis?
Adenomyosis.
Very good. Okay. Next one is you have uterine bleeding, but this bleeding is associated with a normal or a shrunken shape of the uterus. And there is metorrhagia and menorrhagia, meaning excessive bleeding and irregular bleeding pattern. But the uterine shape is normal, and there's also abdominal pain associated with this. What is your diagnosis?
Endometriosis.
Very good. You have another patient who has uterine bleeding after the age of 60. What is the most possible diagnosis? Malignancy. Very good. You have another patient who has a uterine endometrial thickening more than 11 millimeters on an ultrasonogram, and there's uterine bleeding. What is your diagnosis?
Endometrial thickening, or
This is called endometrial hyperplasia. Okay. Endometrial hyperplasia. Okay, very good. Thank you so much, Dr. VK, for helping us out. Did everyone understand
Thank
Dr.
you, Doctor.
VK's answers? Yes or no? You're welcome. Yes. Okay. So can we expect questions to come based on the description of bleeding? Yes or no? The answer is yes. Okay. So we'll talk about this more in details. Let's move forward to pregnancy. Now, pregnancy, fertilization most commonly occurs in the upper end of the fallopian tube. Very important line. Please put your star mark for this. That fertilization happens in the ampulla of the fallopian tube. After 1 day, you have implantation in the uterine wall, basically in the posterior uterine wall. And syncytial trophoblasts secrete HCG. Very important. We know this, that cytotrophoblasts are responsible for what? Synthesis of cells. And syncytial trophoblasts is responsible for synthesis of hormones, as simple as that, HCG. Okay. Embryonic age is time since fertilization, and it's used in embryology. Gestational age is time since first day of last menstrual period, and it's used clinically. Okay, so that's that. Next one is gravida. Gravida means how many times the uterus had a viable pregnancy. So there could be multi-gravida, but parity could be 0. That is, for example, if there is a patient with 5 abortions in the past, can we call them 6th gravida with 0 parity? Yes or no? The answer is yes. Okay, so that's it. Parity means how many live births, or how many live births do they have, as simple as that. So primary gravid is basically what? A female who has just gotten pregnant for the first time. Yes or no? The answer is yes. And what do we mean by nulliparous? Means no live pregnancies. Yes or no? The answer is yes. What do we mean by multiparous? Meaning multiple live pregnancies. Yes or no? The answer is yes. Okay. Okay. Very quickly, this diagram over here, very, very important for identification. As you can see, HCG increases and then HCG falls. Estrogen, progesterone, prolactin, and human placental lactogen, they will keep on increasing like this in this pattern. Okay. Estrogen will be less than progesterone. Just remember that. And the more progesterone we have, the less prolactin there should be. So when progesterone rises, prolactin falls. So this is your prolactin level, and this is HPL. This identification of the hormones, they're very, very important for your step 1 exam. So very quickly over here, it only takes a second to talk about this. There's this one, then there's this, and this falls and rises a little bit. And then there's this. So you have A, B, C, D, and E. A is which hormone? Fast answers, please. A is HCG. Very good. B is which hormone? Fast answers, please. B is estrogen. Very good. C is which hormone? Fast answers. C is progesterone. D is prolactin. E is human placental lactogen. Okay. HPL. How simple. Okay. Next one. Next one is physiological changes in pregnancy. Very, very important. So what are the changes that happens in a woman physiologically when they are carrying fetus? So usually what happens is that over here, first and foremost, if there's a mother who's carrying the fetus, should they have changes in their blood supply? Yes or no? The answer is yes. Why? They should have changes in their blood supply that should allow more blood supply to the fetus or less blood supply? The answer is they should have changes that should allow more blood supply. So blood supply has to increase. Should there be high afterload or low afterload? Fast answers, please. There should be low afterload. So afterload should be low. Blood volume will be very high. So cardiac output increases, and heart rate is the major contributor, right? And what happens is when we have a high amount of blood flow, the high hydrostatic pressure, can they cause fluid to accumulate in the interstitial space? Yes or no? So mothers, can they get swollen up because of peripheral edema? Yes or no? So they have a lot of fluid accumulation. The answer is yes. Okay. Next one is endocrine changes. Endocrine changes is that mothers, when they gain weight, and also due to progesterone, always remember this, that due to progesterone, insulin resistance and insulin, there is a resistance to insulin, meaning that insulin cannot work properly. As a result, there could be hypoglycemia. So increase lipolysis and utilization and fat to preserve glucose and amino acids. As a result, what happens is over here, we want to make sure that the glucose supply to the fetus is maintained at all times. So what happens is over here, if there's a high amount of insulin, will the mother's cell take up all the glucose? Yes or no? Fast answers, please. The answer is yes, right? So what happens is due to progesterone, there's some amount of insulin resistance that allows for the glucose to stay in the blood so that the fetus can get the glucose supply. But in turn, what happens is this puts the mother at risk of developing reversible or non-reversible gestational diabetes mellitus. Okay. If they ask you a question, which hormone is responsible for this? The answer is progesterone. So if you guys want, please write this down. Next one is GI motility. Motility will decrease, and this predisposes to constipation because if there's uterine enlargement, they can press on the large intestines, and a lot of mothers, they will be prone to develop constipations and problems related to constipations. There could be diverticulosis, there could be anal fissures, right? And different sorts of problems. And they can also get gallstones, very important. Gallstones are very high yield in pregnancy. The question is, which hormone decreases the gallbladder motility? The answer is, again, progesterone. Progesterone is responsible for decreasing the gallbladder motility. So there's a higher chance of having a gallbladder stasis, that is a decreased movement, which allows for the cholesterols to get formed into a cholesterol stone. So that's it. Hematological patients can get dilutional anemia. They can be in a hypercoagulable state to decrease blood flow. And increased micronutrients require predisposition to deficiency iron and folate. That's not important. What's important is cardiovascular system changes, endocrine system changes, and gallstones. Next one is musculoskeletal, not important. Patients can get lordosis. Skin is important in the sense that we get melasma in the skin, linea nigra, and areolar darkening. That's not also very high yield, so I'm going to use my blue pen for this. Okay, melasma, linea nigra, and areolar darkening. Another one is that we can get spider angiomas, palmar erythema, and varicosities. Which hormone is responsible for this? Spider angiomas, palmar erythema. The answer is estrogen. Okay, so that's it. Next one is renal. Renal is vasodilatation. We can get renal plasma flow, GFR increases. We can get mild glucosuria and proteinuria. That's normal in your pregnancy. And sometimes if we get severe dilatation, then that can cause backflow of the blood, and that can cause hydronephrosis and pyelonephritis. So just to make you guys understand, what are some diseases that are very high yield in pregnancy? Due to the normal physiological changes in pregnancy, number one, can we get peripartum cardiomyopathy? Yes or no? Fast answers, please. Yes or no? Yes. Number two, can we get gestational diabetes mellitus? Yes or no? The answer is yes. Can we get diverticulosis, constipation, anal fissures? Yes or no? The answer is yes. Okay. Can we get iron deficiency, anemia? Yes or no? In hematological disease? The answer is yes. Can we get lordosis? The answer is yes. Next one is, can we get spider angiomas, palmar erythema, and varicosities? Okay. The answer is yes. Can we get pyelonephritis? Yes or no? The answer is yes. Okay. And another thing is, can we also get appendicitis due to fecal accumulation in the appendix due to constipation? Yes or no? The answer is yes. Okay. Now, all of these things, should they be addressed very quickly, despite if the mother is carrying the child or not? Yes or no? The answer is yes, meaning that who will you give more priority to in your pregnancy? The mother or the baby? The mother. Okay. Why? Because if the mother doesn't survive, the baby doesn't survive. That's simple. Okay. So that's it. Respiratory, you have a respiratory center stimulation. For example, we have hyperventilation that happens in pregnancy because it makes sense, right? Because the mother is not only trying to get rid of her carbon dioxide, the mother is also trying to get rid of the fetal's carbon dioxide. So do you think that the lungs should work more or work less to get rid of the carbon dioxide? The answer is the lungs should work more. Yes, very good. Okay. Now let's move on to another discussion of another hormone, that is HCG. This is secreted by the syncytial trophoblast of the placenta, very, very high yield. We know what HCG does, right? The corpus luteum that secretes the progesterone, it's maintained by HCG that is secreted by the syncytial trophoblast. That's a very high yield function for maintaining the corpus luteum. This is actually asked in the Usmle step 1. So that's that. And it's important because HCG that is secreted by the syncytial trophoblast, if they maintain the structure of the corpus luteum of pregnancy, can we have a sustained supply of progesterone in the early phases before progesterone is synthesized by the placenta? The answer is yes, right? So that's that. HCG is also used to detect pregnancy. And another thing is HCG has identical alpha subunits as FSH, LH, and TSH, and beta subunit. So the question is that can we have ectopic or can we get hyperthyroidism if HCG is very high? Yes or no? The answer is yes. If you ask me why, then that's because the structure of these hormones are very similar. Okay, that's simple as that. Another thing is HCG has two subunits, alpha subunit and beta subunit. The alpha subunit is very similar to FSH, LH, and TSH, and the beta subunit is important for what? Can we say that the beta subunit is the one that is detected in the pregnancy test? Yes or no? The answer is yes. Okay, so please remember this. Beta subunit is unique. Okay, so 3 stars, 1, 2, 3, 4, 3 different types of questions. I'm over here. Okay, HCG is decreased in ectopic pregnancy or failing pregnancy, and Edwards and Down syndrome, but Down syndrome. So that's also very high yield. Okay, another thing I need you to identify over here is that HCG is high in Down syndrome, by the way. Okay, and HCG is low in Edwards syndrome and Pathology syndrome. So that means in trisomy 21, HCG is high. In 13 and 18, HCG is low. Okay. Okay. Another one is HPL. HPL is human placental lactogen. That is also called my apologies. That's also called chorionic somatomammatropin. Chorionic somatomammatropin or human placental lactogen. This is synthesized once again from the syncytial trophoblast, and this is responsible for stimulation of insulin production. This overall increases insulin resistance. So very quickly, what are the 2 hormones that are responsible for insulin resistance? Number 1 is progesterone. Number 2 is human placental lactogen. Are we clear? Yes or no? Last chances, please. Okay. Do we get more gallstones in pregnancy? Yes or no? The answer is yes. Why? Because of progesterone. Yes. The progesterone, what do? They cause gallbladder stasis. Okay. Okay. Can we move forward? Yes or no? Is everyone ready? Can we move forward? Yes. Okay. So APGAR score is something that I'll discuss at the end of today's lecture. Can I move on to lactation for now? Okay. So let's move on to lactation. What is lactation? Lactation is basically a physiological process where we have the milk let down reflex, right? This is important for the maintenance of the nutritional needs of the first 6 months of human life, right? So after parturition and delivery of the placenta, what happens that the progesterone falls rapidly, and this rapid fall of progesterone increases prolactin. This increase of prolactin causes initiation of lactation, as simple as that. And how do we initiate lactation? First of all, when mothers, when they hear their babies crying, for example, is there a possibility that this induces the release of more prolactin from the posterior pituitary? Yes or no? The answer is yes. And then after that, what do they do? Do they address the baby's crying by realizing that the baby is hungry? Yes or no? The answer is yes. So then they initiate the process of breastfeeding. So during the process of breastfeeding, when the baby is suckling, is there a possibility that stimulates the release of oxytocin? Yes or no? The answer is yes. That oxytocin that is secreted, oxytocin works by what? IP3 DAG, right? IP3 DAG. IP3 DAG is inositol triphosphate and diacylglycerol mechanism. This mechanism is responsible for increasing the entry of calcium, yes or no? When calcium enters into the ducts, can this cause contractions of the glands? Yes or no? The answer is yes. This contraction of the glands, can they cause the release of the milk? The answer is yes. That's simple. So that's what we mean. So prolactin will induce and maintain lactation. And also, when the prolactin level is very high, is the GnRH level low? Yes or no? The answer is yes. So during high levels of prolactin, do we have more chances of conception or less chances of conception? The answer is we have less chances of conception. But nowadays, do we use breastfeeding as the only method of contraception in the first 6 months? The answer is no. Maybe in the past it was used, but nowadays we use another method. Okay. So oxytocin is another hormone that is responsible for lactation and milk letdown. I just told you how and how we do this. Breast milk is the ideal nutrition for infants less than 6 months. It contains a lot of different types of high yield substances. One of the most important things is that it contains immunoglobulins. That's very high yield, especially IgA. They also contain macrophage, lymphocytes, and everything else. And guidelines recommend exclusively breastfeeding. Infants should also get vitamin D. This is a very high yield step 1 question, and iron. The question goes something like this. That is, in the first 6 months of pregnancy, what are the nutritional requirements of the child? The first 6 months of pregnancy, the nutritional requirements of the child is number 1, breastfeeding and breastfeeding only. That is called exclusive breastfeeding. And along with this, supplementation with vitamin D and iron. Have I made myself clear? Yes or no? Okay, so that's it. Next one is menopause. What is menopause? Menopause is when we have a female who experiences a 1-year cessation of menstruation. When we say, we use the word amenorrhea, meaning absence of menstruation for more than a year in a female with a previously normal menstruation, right? So what happens? Why do we have this? This onset of menopause is basically the sign that the limited supply of ovums which the female had throughout their lifetime, it's almost coming to an end, right? So the estrogen production will fall, and the average age is around 51 years, more or less. And it's usually preceded by 4 to 5 years of abnormal menstrual cycles. So patients who are in the perimenopausal time, meaning that the timing around the onset of menopause, that's the age, for example, from 45 and above, these patients, they will have certain complications due to the hormonal imbalance. For example, they can have complications regarding temperature, they can have complications regarding their mood, they can have complications regarding the blood flow and everything else. That's all due to the hormonal imbalance. But the source of estrogen after menopause becomes peripheral conversion of androgens, meaning that the source of estrogen after menopause, since there is a depletion of the ovum, so the theca cells and the granulosa cells, they cannot function to create more estrogen. So now after menopause, the source of estrogen in females becomes solely dependent on the adipose tissues. Right, on the adipose tissue. So the more fat the females have, the more estrogen that they have. That's not necessarily a very good thing, because females after menopause should not be exposed to high amount of estrogen, because that can result in uterine carcinomas and hyperplasias and all of those things. Okay, so that's it. Another one is that during the menopause, the estrogen level is so low that FSH is usually very high. So this high FSH is usually used as an indicator to let us know if a female is at the onset of menopause or not. So that makes sense, because we have hypothalamo-pituitary-ovarian axis. The hypothalamus secretes GnRH, which induces the pituitary gland to secrete FSH and LH. FSH and LH stimulates the theca and the granulosa cells to create estrogen. Once we have decreased ovum in menopausal time, the FSH will keep on rising. But will we have estrogen to have a negative feedback on the pituitary? Yes or no? The answer is no. As a result, FSH should be very high or very low. The answer is very high. As simple as that. So in some females, to decrease the menopausal symptoms, right? For example, hot flashes, vaginal atrophy, osteoporosis, coronary artery disease, and sleep disturbance, can we initiate hormone replacement therapy? Yes or no? If it's too severe, the answer is yes. In some females, we can give them estrogens. And another thing I need you to understand about this one, atrophy of the vagina, very, very high yield. Vaginal atrophy is very high yield because this actually puts the vagina at risk of a lot of different types of pathology. For example, we can have vaginitis, then friction vaginitis. Females can have a very high yield disease that's known as lichen sclerosis. Have you guys heard of lichen sclerosis? Yes or no? Which is more common in menopausal area. That is the area around the vulva, they get thickened. So lichen sclerosis is usually treated with high potency glucocorticoids, right? And sometimes for mild vaginal atrophy, we can also give estrogen creams. So that's it. Menopause before 40 usually suggests primary ovarian insufficiency or premature ovarian failure. This is the same thing I talked about. And this can either be idiopathic or this can happen because of a history of chemotherapy or radiation. Let's say that there's a female who needed chemo or radio for some sort of a carcinoma. That radiation that she was exposed to was responsible for destroying all the ovum. So that's why she suffered from primary ovarian insufficiency or premature ovarian failure. Okay, so that's it. Before I move on very quickly, I just want to ask you guys a couple of questions very quickly. The proliferative phase of menstruation is dependent on which hormone? Fast answers, please. Proliferative phase, estrogen, very good. Secretory phase is responsible for which hormone? Fast answers, please. Okay, syncytial trophoblast of the placenta will create two hormones. One is what? Fast answers, please. One is HCG, another one is HPL. Very good. HPL, is it responsible for insulin resistance? Yes or no? The answer is yes. What is the name of another hormone that is also responsible for insulin resistance? Progesterone. What's the name of the hormone that's responsible for gallbladder stasis? Gallbladder stasis, progesterone. Very good. What is the name of the hormone that has alpha subunit identical to FSH, LH, TSH? Answer is HCG. HCG. Very good. Okay. Next one is, what is the name of the hormone that is excessively high in menopause? Fast answers, please. The name of the hormone that's excessively high in menopause. Very good. FSH. Okay. What is the source of estrogen after menopause? Fast answers, please.
On it. I didn't find God. Okay, next one is what on Apple Music?
Yeah, my apologies. Aromatization. Okay. Next one is, what is the name of the hormone that is working in the theca cells? Fast answers, please. Theca cells, LH. What is the name of the hormone that's working on Sertoli's granulosa cells? FSH. Very good. What is the name of the substance that is moving from the theca cells to the granulosa cells? Androstenedione. What is the primary substance from where estrogen is produced? Cholesterol. Okay, good. So you guys are aware of all the physiological things, yes or no? I'm pretty sure. Can I assume your answers to be an indicator that you guys have understood the lecture, yes or no? No? My question is, can I assume that your answers are an indicator that you guys have understood the lecture for today, yes or no? Yes, okay, good. Okay, good. Let's move forward to androgens. Is everyone ready? Yes or no? Androgens, is everyone ready? Yes or no? Okay, so let's talk about testosterone. Testosterone is the #1 androgen, right? What do we mean by the #1 androgen? That means that testosterone is responsible for initiation of secondary sexual characteristics, especially in males, right? Especially in males. So that's it. So there's androstenedione, and then from androstenedione you have testosterone, and testosterone is converted to dihydroxytestosterone by 5-alpha reductase. So dihydroxytestosterone is one of the most important substance. So function of testosterone is very simple. Differentiation of the male reproductive system, growth spurt for males, deepening of voice. This is very important. You guys remember I told you if there's a female who comes to you with voice deepening, is it due to internal secretion of androgens or exogenous secretion of androgens? Which one? Exogenous source. Always remember this. Closing of epiphyseal plates, very important, and male and female libido. Dihydroxytestosterone is also very important. It's responsible for differentiation of the penis, scrotum, and prostate, and for late for prostate growth. So that's understandable. Another thing that I want to bring to everyone's attention is high testosterone is directly related to balding. So males who are bald, that's more or less a very good indicator that the testosterone amount in the male is very high. As simple as that. Okay. So females who experience voice deepening and hair loss, is there a possibility they can have exogenous steroid abuse? The answer is yes. And for US, how important is your understanding or your process of understanding the exogenous steroid abuse for US? The answer is it's very, very important. Yes, because the US is basically a group of, I mean, it's a community where we emphasize a lot more on our personal appearances, our physical appearances, our strength, and going to the gym, right? And there are people, if they get really obsessed with this, for example, we have professionals who do this under the influence of endocrinologists and everyone else. So that's actually okay, because they are professionals and they are professional competitors, meaning that they will be on stage who will be performing. So that's completely understandable for them to do whatever they have to do in order to have their growth. But people who are not professional bodybuilders, or if there's anyone who is abusing steroids without the influence of endocrinologists, especially females, can they get in severe trouble? Yes or no? The answer is yes, right? There could be not only deepening of voices, loss of hair, can we also expect the growth of different sorts of tumors and carcinomas in a female who is abusing steroids without proper medical help? The answer is yes. Very, very important. Okay, especially for US, it's absolutely important. Next one is testosterone is converted to dihydroxytestosterone by 5-alpha reductase. This is something which we can inhibit by finasteride. That is, this is a drug that we use to treat male pattern baldness. So in males, androgens are converted to estrogen by aromatase. That's another one. So for example, can we expect males who are really obese to have female-like features like gynecomastia, spider angiomas, palmareatimas? Yes, the answer is yes. Why? Because males who have a lot of fat are at risk of converting their testosterone to estrogen, because fat cells are adipose tissues, which contains an enzyme called aromatase that will convert your testosterone to estrogen. Next one, can females use aromatase inhibitors for their bodybuilding purposes to make sure that they have more testosterone and less estrogen? The answer is also yes. Okay. Okay, next one, anabolic and androgenic steroid use, very important. It increases fat-free muscle strength, performance, and it is suspected in males who have changes in behavior. Number one, how many of us have heard of the term steroid rage? We call this roid rage. Is there anyone who has heard this? Yes or no? Roid rage. There's a very famous, okay, how many of us have heard of WWE's, World Wrestling Entertainment, wrestling, right? Okay, no. Okay. So I'm pretty sure you guys have not seen WWE, but you guys have heard about wrestling, yes? Okay. So a lot of wrestlers in the past, they were on the receiving end of going through or being victims of roid rage. So what happened was that they would abuse testosterone, and you know what testosterone does. And when there's a high level of testosterone, that is severely linked to increase release of different sorts of neurotransmitters such as serotonin, dopamine, and everything else. So that actually creates an excitatory effect in the entire body. So over here, that actually creates an excitatory effect in the entire body. So as a result, these males, they can experience severe anger, and we call this roid rage. This is a very important topic to talk about in Step 2 CK, because we get a lot of different types of questions related to this. Testosterone is also related to acnes, especially acnes that we get in males and females who abuse testosterone. They appear in the back, they appear in the face. We can also get gynecomastia because of excessive testosterone being converted to estrogen. And we can also get polycythemia. Please remember that. Another thing is, when testosterone is being taken from outside, the normal testis, is it going to produce testosterone? Yes or no? The answer is no, right? So what happens when we take testosterone from outside? Can we have a negative feedback on the FSH and LH? The answer is yes. As a result, stimulation of the testis, can it be decreased? Yes or no? The answer is yes. So patients who abuse steroids, can they have small testicles or Testicular atrophy, yes or no? The answer is yes. Okay, so that's very important. Decrease in testicular size, decrease in testosterone, decrease sperm count, and infertility. Females will experience virilization, hirsutism, acne, breast atrophy, and male pattern baldness. Very important. Okay, next one. Let's talk about the Tanner stages very quickly. This is something which we are all aware of, and Tanner stages are important because they use this in your question to help you understand at what stage a female or a male is usually in. So let's talk about Tanner stages. We have 5 stages over here. This is the stage 1, is the pre-pubertal stage. As you can see, that there is the difference between stage 1 and stage 2 is, let me tell you something. The easiest way that you can remember this. Stage 1 is the primary stage of male and females. The difference between stage 1 and stage 2 is the appearance of pubic hair. Very important. Then the difference between stage 2 and stage 3 is that in stage 2, there is appearance of pubic hair in males and females, but there is no growth of the sexual organs. The difference between stage 2 and stage 3 is that along with pubic hair, now you have enlargement of the sexual organ. So you have enlargement of penis and you have an enlargement of the female breasts. That's that. What is the difference between stage 3 and stage 4? The difference between stage 3 and stage 4 is that there are changes in the characteristics of the pubic hair. In stage 3, it's more smooth. In stage 4, it takes a more coarse appearance, meaning that it gets more deeper. And obviously, you have further increase in size of the sexual organs. And stage 5 is the last stage. This is usually above 15 years in any male or female, where they have the last stage of the pubertal development. That is, the penile length comes to the normal size, above which it will not grow anymore. The breasts come to a normal size, above which it can only grow during pregnancy or not anymore. And that's that. So very quickly, in stage 1, do we have pubic hair? Yes or no? Fast answers, please. Yes or no? Fast answers. Stage 1, pubic hair? Yes or no? No, the answer is no. In stage 2, do we have pubic hair? Yes or no? Yes. In stage 3, do we have lengthening or increasing size of the sexual organs? Yes or no? The answer is yes. In stage 4, do we have coarsening or deepening of the pubic hair? Yes or no? The answer is yes. In stage 5, do we have the final development of the sexual organs? The answer is yes. Okay. So when I say, for example, stage 2, Tanner stage 2, are we thinking about patients who have no increase in size of their sexual organ, but only in appearance of the pubic hair? Yes or no? The answer is yes. Okay. Now, what is the Tanner stage for this patient who has coarse pubic hair, increase in length of the sexual organs? That's answer, please. This is Tanner stage 2, 3, 4. Which one? 3. Very good. Okay. So I'm pretty sure you guys have understood this. Now, again, differentiate one stage from another, and this is the easiest way that you can understand this. Okay. Let's move forward to precocious puberty. Is everyone ready? Yes or no? Okay, what is precocious puberty? Precocious puberty is when we have early onset of puberty before the normal age. So the normal age of puberty is 8 years in females and 9 years in males, right? If we get onset of secondary sexual characteristics before 9 years in males or before 8 years in females, we call this precocious puberty. This could be idiopathic, right? And this could also be pathological. If it's pathological, then we are thinking that there's an excessive release of testosterone or estrogen. For example, if we have a pituitary tumor, is there a possibility that we can have early secretion of excessive testosterone? The answer is yes, right? Or if we have sertoli and a Leydig cell tumor, can we get excessive secretion of the sex hormones? Yes or no? The answer is yes. Okay, so that's that. So appearance of secondary sexual characteristics before age 8 years, increase in sex hormone exposure or production will cause linear growth, somatic and skeletal maturation. And there could be 2 types, central or peripheral. Central means that there's excessive secretion of GnRH, and peripheral means that there's increasing secretion of the sex hormones without the influence of GnRH, as simple as that. Okay, so this could be congenital adrenal hyperplasia. For example, what is the congenital adrenal hyperplasia where we get early precocious puberty? 21, 11, or 17 hydroxylate deficiency? Which one? Fast answers, please. The answer is we can get them in 21 and 11. Yes or no? Can we get them in 21 and 11? Yes, the answer is yes. Okay. So that's that. Estrogen secreting tumor. This could be Leydig cell tumor or Sertoli cell tumor. This could be theca granulosa cell tumor, right? And there's another one called McCune-Albright syndrome. McCune-Albright syndrome is when we have polyostotic fibrous dysplasia along with precocious puberty. I'll talk about this later. Polyostotic fibrous dysplasia. What does this name suggest? Can we have the attention of Dr. Ethar very quickly? If you can unmute yourself, please say yes or no. Can we have the attention of someone who can unmute themselves and answer me some question? Can we have Dr. VK very quickly? Anyone who can unmute themselves and answer a question very quickly? Dr. Ethar, okay. Please unmute yourself and answer the question. What was I talking about? Right. Oh, I was talking about polyostotic fibrous dysplasia. What does this name suggest? Do you have any idea? How can this disease be
Yes, it's
described?
the McCune-Albright. It's when the bone is the collagen in the bone is replaced by fibrous tissue, I think.
Very good, very good, oh, very good. Okay, so polyostotic, meaning multiple bones undergoing a fibrous change in their architecture. So each and every word. Polyostotic means multiple bones, fibrous means fibrous, and dysplasia means abnormalities in their architecture. So bones being replaced by fibrous tissue and precocious puberty happening at the same time. This is called McCune-Albright syndrome. That's what I wanted to talk to you guys about. Did you guys understand McCune-Albright syndrome? I'll talk about this in details, but for now, did you understand the term polyostotic fibrous dysplasia? The answer is yes. Okay. The name will always suggest the disease pattern. Please remember that. Okay, so we're done with physiology over here. One last thing before we close down the lecture for today. That is APGAR, or we call this ABGAR scores. Okay, is everyone ready? Yes or no? Okay, ABGAR scores are scores that are given by pediatricians or not? Yes or no? They're given by pediatricians, right? So the thing is, ABGAR scores. ABGAR, what does this stand for? Number one, how many of us have had the history of working in a gynecological setting? Please say me. If there's anyone? Yes, okay. Have you guys ever conducted a delivery? Yes or no? If you have worked in gynecology, then you have conducted deliveries. Yes or no? Fast answers, please. Okay. Right after you have conducted a delivery, have you asked your pediatrician of the hospital to come and assess the patient immediately? Yes or no? The answer is yes, obviously. So when the pediatrician comes, does he give you an assessment of the patient based on this score or not? Yes or no? Okay. The answer is yes. Okay. Very good. So ABGAR scores for each point A, P, G, A, R. We give 2 scores: 2, 2, 2, 2, and 2. So total score is 10. If there's any pediatric patients who scores less than 7, they need immediate attention in NICU, neonatal intensive care unit. Have I made myself clear? Yes or no? Okay. Now, what are these scores? A stands for what? Appearance. P stands for what? Pulse. G stands for what? Grimace, or basically this is your understanding of muscular contraction. Activity stands for what? Movement. R stands for what? Respiration, right? So we have each scores. For example, we have, when do we give scores 2? When do we give scores 1? And when do we give scores 0? If the baby appears pink, then we give them 2. If the baby appears pink in the middle, these parts are pink, but the extremities are blue, then we give them 1. And if the baby is completely blue, we give them 0. Okay. Pulse. More than 100 is 2. Less than 100 is 1. And no pulse is 0. Grimace means when you stimulate, do they contract or not? For example, if you pinch the child, if they cry, that's 2. If the cry is weak, then that's 1. And if it's no crying, then it's 0. If there is movement of all 4 limbs, then it's 2. If the arms and legs are moving very slowly, it's 1. If it's absent, it's 0. Respiration means strong respiration. They're crying very loudly. We usually like babies who cries very loud in the early stages because that represents respiration. If the crying is slow, then it's 0. No crying is for 0. Okay, so we assess them. So first of all, number 1, if we have a baby who comes to you with a pink face, the baby is actively crying, moving, the respiration is very strong, and they cry and they pull away. What is your diagnosis? What is the score for this patient? If there's a baby who has, okay, so I'm pretty sure you guys understand, okay? You guys understand how the APGR score works or not? Yes or no? Because I'm pretty sure this is not the first time you guys are hearing this. Yes, okay. So that's that. So this is important. I'm gonna tell you why it's important. In your step 1 exam, they will not ask you to assess the APGAR score, okay? In your exam, they will tell you the APGAR score at 1 minute and at 5 minutes. If you see that the score is below 7, then try to understand that this is that this fetus this baby is at risk of neurological damage. As simple as that. Okay. Are we clear? Yes or no? Last chance, please. Okay. Next one is low birth weight. What is low birth weight? If there's any child who is less than 2.5 kilograms, they are considered as low birth weight child. Okay. And these children, are they at risk of sudden infant deaths and overall mortality? Yes or no? The answer is yes. Okay, so that's all about my discussion for the reproductive system, where we have completed physiology. So thank you so much. Now, very quickly, did we understand physiology, which we have completed today? Yes or no? Yes. Okay. Can we assume that we did a lot of pages today? How many pages did we do today? Can anyone tell me? How many pages did we do today? Oh, 13 pages. So that's very good. I think we should keep the lecture up to here for today. And tomorrow we will begin with reproductive pathology. Okay. Now, I tried my best to help you guys understand all the questions you will be asked from reproductive physiology. So next time when you study first aid, will it be easier for you to address the more important ones and the less important ones? Yes or no? Okay. The answer is yes. Okay. So that's that. And if you guys do not solve the UWorld question associated with this, can you forget this information very quickly? Yes or no? The answer is yes. Okay. Okay. Now, I want to keep the lecture up to here for today. Tomorrow we will do some amboss questions. Today I actually want to keep it up to here because I started the lecture a little bit late. Tomorrow we'll start a little bit early and we can do some questions from amboss. In the meantime, please try to make sure that you guys solve the UWorld questions. Okay. Now, very quickly, I just want to ask everyone: are you guys receiving the recordings on time? Yes or no? Last chances, please. Is everyone receiving the recordings on time? Yes or no? Okay. Can we have it at 10:30 every day? I think that's actually better. Instead of 9:30, let's change our class timing to 10, not 10:30. 10:30 is a little bit late for me because I also want to do some questions with you guys. Okay, so 10 should be okay. Are we clear? Yes or no? 10 a.m. Okay, so that's that. Now, whoever wants to leave, they can leave while I address the situation of the biostatistics, so that I can make sure you guys are receiving it right now. I see a lot of students who has not received biostatistics statistics lecture. I'm not sure why. So let me just upload the lecture over here very quickly. And if you guys want to leave, then you're more than welcome to do so. Thank you so much for putting your attention in the lecture. Please make sure that you guys come to class on time at 10 a.m. We have another class today starting in the evening for evening batches. If you guys want to come and join the class for free, the first 1 week is free. We will start with CVS again. So you guys are more than welcome to join. So, and if you want to continue with both classes, the one in the morning and the one in the evening, so please reach out to me so that I can give you the instructions for completing your payments so that you can join the both classes. Okay, so for that's that. Thank you so much. For now, you guys are welcome to leave while I address the biostatistics, and then I will end the class. Okay, thank you so much. In the meantime, does anyone have any question? If you guys have questions, please let me know. Okay. Yes, please unmute yourself and ask me the question while I do this work.
Welcome, Dr. Hedri. By what time will be the evening lectures?
5:30 p.m.
All right. The reason I am asking is that I might be going to US in end of February. So
Okay.
I don't know. By 9:30 it will be difficult for me to join from there.
Okay.
So 5:30 should be more feasible.
Wait. You're going to US to which state?
Might be Texas.
Oh, okay. So the Texas timing is very similar to our timing. It's Eastern timing. So 9:30.
Yeah, but in the morning,
Oh,
I
in the
will
morning,
be
do you have?
rotating.
You will be?
Yeah, for clinical attachment, so I'll be rotating, right?
Oh, you'll be rotating. Makes sense. Yes, that's very important. I'm actually really glad that you're taking this initiative right now. So that's very smart of you. So in that case, if you cannot do the class in the morning, you have two options. Either you can join the evening batch or you can use the recordings in the morning to learn.
Okay.
Okay. So that's that. And any other question? Yes or no?
Would you be kind enough to let me know by late February where will be the batch in terms of the session? Like, will you be doing repro or something else, or biostats, or
For the morning batch or the evening batch?
the evening batch?
Evening
Do you
batch,
have
we will do evening batch. We will do it exactly how we did your batch. That is, we'll start with CVS.
Okay.
We'll do endocrinology. We'll never do renal, and then
Okay.
we will
All
move
right.
on to the other one. Okay. Any other question?
Fine. No, thank you.
You're welcome. Okay. Okay. So thank you so much. Hope you guys have a great day. I'll see you guys tomorrow at 10 a.m. Okay. Bye-bye now. And everyone should receive the biostatistics invitation to their lecture, to their email. Please open the email and ask me to invite you in, and you guys can view the biostatistics lecture. Okay. Thank you so much. I'll see you guys tomorrow. Bye-bye.